we will do the nasal septum. Now nasal septum forms the medial wall of the nasal cavity and it is vertical in position while the lateral wall is oblique and having the three elevations, the three concava, superior, middle and inferior. But septum is straight and vertical and it is covered in most of its lower part, the ciliated columnar epithelium which also lines the lower two-thirds of the nasal cavity, while the upper one is the olfactory mucosa lining the upper or the roof of the nasal cavity as well as the lateral wall, and the same is the medial wall, that is the nasal septum. So lining is the ciliated columnar in the lower part and the olfactory mucosa in the upper part. So the nasal septum separates the cavities right and left. And it is formed by two parts. One is the bony part and other is the cartilaginous part. Bony part is formed by the perpendicular plate of the sphenoid bone in the upper part. This is the roof, is the cribriform plate. Behind is the lesser wing of the sphenoid bone, and this is the body of the sphenoid bone with the pituitary fossa and the sphenoidal air sinus in it. This is the frontal bone, this is the nasal bone. So in the upper part, it is formed by the perpendicular plate of the sphenoid bone. So this is the perpendicular plate of sphenoid forming the upper bony part of the nasal septum. In the lower part is the hard palate forming the floor of the nasal cavity. This is the hard palate. And it is joined by the vomer, which is a complete bone. Posteriorly it is attached to the body of the sphenoid and superiorly it is attached to the perpendicular plate of the sphenoid bone. So this is the vomer bone and this is called the vomero-sphenoidal junction. Anteriorly it is the free. Inferiorly it is attached to the nasal crest of the palatine bone, and then posteriorly it is also free and from the posterior nares. Anterior part is cartilaginous. This is called the septal cartilage, but near the lower part, anterior part, this is the true skin. Of this part. So this is the cartilaginous part of the. So in the posterior part is attached to the perpendicular plate of the sphenoid, and this septal cartilage in the posterior and the inferior part is attached to the anterior free border of the vomer. Inferiorly, it is attached to the palatine bone, and most of the anterior part, it is attached to the skin of the tip of the nose. So this is the septal cartilage. And it is movable also. So this is the anterior part of the nasal septum is movable. And this is the formation of the nasal septum. Its blood supply is very important because there is a area which is called the Little's area. Little's area is also called the area of the epistaxis. And this area is actually the meeting place of the four arteries. One is called the anterior ethmoidal artery, then sphenopalatine artery, then the septal branch of the superior labial artery, and the septal branch of the greater palatine artery. So all these arteries, then the anterior ethmoidal artery comes here, then the sphenopalatine artery branch of the maxillary artery comes here, and the superior labial artery which supplies the upper lip. It also gives the septal branch which also comes here, and the greater palatine artery which runs on the inferior surface of the palate, which also contribute in the formation of this anastomosis. So four arteries, they form an anastomosis on the nasal septum. So this is called the Little's area, or this is called the area of the epistaxis. So it is very clinically important structure in the nasal septum. Then after this, nasal septum is again important because of the bleeding or epistaxis. Various causes of the epistaxis, most common cause is the trauma. So any direct injury or the roadside injury can injure the Little's area because it lies just on either side of the septum, and this damage and leading to the bleeding. Second is in the summer. In the summer, when the hot air goes into the nose and the nostril, then the mucous membrane which is covering the Little's area, because of the dryness and the hot air, cracks. And with the cracking of the mucous membrane overlying the Little's area, these arteries, they are ruptured. And the damage of the injury of these arteries lead to the epistaxis. Third, another cause is common is the hypertension. Patients of the high blood pressure, they are admitted only first time in the life when they got the episode of the epistaxis. So hypertension is one of the common cause in the hypertensive patient for the epistaxis. Then the bleeding disorders. So all diseases related to bleeding disorders, the leukemia, hemophilia, and other clotting factor deficiency, so they also prone to the epistaxis. So these are the common causes of the individual in which the bleeding is very, very common. Then how to control it? We have to press the nose with the thumb and the finger, because we know the Little's area lies just at the junction of the septum and the bony part. And it lies just anteriorly, so we press gently, bilaterally for 5 to 7 minutes, that is the bleeding time and the clotting time. So pressing bilaterally will press the capillaries and prevent the bleeding. During that period, patient will do the mouth breathing. So this is how to tackle with the epistaxis. But if the underlying cause is the hypertension, then this maneuver won't stop it. As you release it, there will be again bleeding. So we have to treat the root cause. So first we have to control the blood pressure, then it will be automatically withdrawn. In the hemophilia or in the bleeding disorder patients, when the epistaxis comes, so that is not done by the pressing just. In that case, we give the paraffin nasal packing. So paraffin nasal packing for 24 hours or 48 hours will stop the bleeding. So these are the measures we take during this. Another applied anatomy of the nasal septum is the DNS. DNS is the deviated or deflected nasal septum. So usually it is congenital, but it may be traumatic also. Congenitally, some people are born with the nasal septum which is tilted on one side, and usually this occurs at this junction, that is the vomeroisthmoidal junction. So bone at this junction is usually overlapped and it is deviated to right side or left side. So this causes the deflected nasal septum. And with the deflected nasal septum, what happens? Main problem to the patient is that patients suffer from rhinitis, because on the deviated side, the serrated columnar epithelium is there, but the inhaled pollen grains, the spores of the bacteria, the carbonaceous particle, dust particle, foreign particle, they get stuck here. And these bacteria, they cause the localized rhinitis, inflammation, and running nose. So on one side, the patient is having the running nose, but on the opposite side, because of the deviation of the septum, the nasal cavity on the other side is widened. And because of the widening, the air currents, they go without touching the ciliated columnar epithelium, which is the defense, first line of the defense. All the carbonaceous dust particle and spores of the bacteria, they have got the easy access to go into our respiratory tract. So the patient will suffer from bronchitis. So chronic bronchitis and chronic cough is the symptom of the patient. Plus, because of the flow of the air, so the affected nose will be, the nasal cavity will be dry. So on one side is wet and other side is the dry, so it gives the unpleasant sensation. And patient will suffer from chronic rhinitis on one side and chronic bronchitis on the other side. So for that, we want to have the treatment, and treatment is the surgical treatment, and the surgical treatment in the nasal or the deviated nasal septum is the SMR. The operation is called SMR operation. SMR is the submucosal resection. Here submucosal resection of the deviated septum is done. So we go anteriorly and we cut the nasal mucosa, and we cut this nasal mucosa and we lift it up, and anteriorly from here we cut a middle piece of the bone which is deviated. So tilted part of the bone is removed, and after the post-operatively the septum becomes the vertical or straight in direction. So we have resected the middle part of the nasal septum, and after a few months it is replaced by the fibrous tissue, and patient won't have got any problem thereafter. So this is the post-operative position of the nasal septum. That's all.